Welcome to The Explainer. Today, we're going on a bit of a medical detective journey. We're going to tackle a classic clinical puzzle, which is distinguishing between two notoriously similar yet entirely different shoulder conditions. To the untrained eye, a patient walking into a clinic complaining of severe shoulder trouble might just look like a generic case of shoulder pain. But as we'll see, the clues are literally hidden in plain sight, if you just know exactly how to look for them. So today, we're dissecting the differences between a frozen shoulder and a rotator cuff tear.
Okay, let's dive into this. Here is our detective's notepad for today. 1. The shoulder showdown. 2. Stiffness or weakness. 3. Phasing the frozen shoulder. 4. Testing range of movement. 5. Gradual decline or sudden trauma. And finally, making your final diagnosis.
Section 1. The shoulder showdown. Here we're introducing our two main suspects, frozen shoulder and a rotator cuff tear, which look completely identical to the untrained eye.
Section 2. Stiffness or weakness. We're moving straight to our first diagnostic clue by exploring the foundational difference in how the patient actually feels.
Before we even lay a single hand on the patient, we absolutely have to ask, what is their main symptom? Now, we aren't just asking if it hurts. We need to know the primary sensation that's actually stopping their movement. How they describe this limitation, well, that is our absolute first key to cracking the case.
So the crucial point here is separating profound stiffness from distinct weakness. A frozen shoulder is, at its core, a stiffness-based condition. The shoulder joint itself is becoming rigid. On the flip side, a rotator cuff tear, and we're especially talking about a large or massive tear here, not just a tiny little snag, is fundamentally a weakness-based condition. The biological hardware is actually broken, so the power just isn't there to move it. To really understand how extreme the stiffness can be in a frozen shoulder, just look at this number. 10 to 20 degrees. That is often the absolute maximum range a patient with a frozen shoulder can achieve in one highly specific, crucial movement. Imagine trying to go about your daily life with only 10 to 20 degrees of rotational freedom in your shoulder. It is severely debilitating.
And that specific movement? It's external rotation, an outward turning of the arm. A severe, debilitating loss of this exact movement is a massive red flag for a frozen shoulder. And the real clincher here, that restriction is present in both the active and passive ranges. It doesn't matter who is trying to move the arm, it is completely mechanically stuck.
Section 3. Phasing the frozen shoulder. Let's shift focus and profile our first suspect in detail by examining its unique chronological development. You see, a frozen shoulder doesn't just appear out of nowhere overnight. From month 1 all the way up to month 9, the patient is trapped in the pain-dominant phase, suffering a really agonizing progressive worsening in both pain and stiffness. But then, right around month 9 up to month 18, they cross over into the stiffness-dominant phase. The pain mercifully subsides, but that severe, locked-in stiffness remains.
Section 4. Testing range of movement. It is time for our second major clue, putting the shoulder through physical movement tests to see exactly how it reacts.
When we test the shoulder mechanics, a profound difference emerges. For a frozen shoulder, both active and passive range of motion are highly restricted. But with a rotator cuff tear, while the active range is restricted due to that weakness we talked about, the passive range of motion is actually preserved. Furthermore, resisted power tests will rapidly expose the cuff tear's weakness while remaining remarkably less affected in a frozen shoulder. Now, what's really interesting about this breakdown is how passive range of movement completely differentiates the two conditions.
To explain exactly why a patient with a massive rotator cuff tear will still have a beautifully preserved passive range of movement, we just have to look at the mechanics. As the literature clearly states, the tendon doesn't need to be active during passive range of movement in order to generate motion. Basically, if a clinician is doing all the heavy lifting and moving the patient's arm for them, the torn tendon isn't even being asked to fire. Therefore, the arm moves perfectly fine passively, which instantly exposes the weakness of the cuff tear rather than a stiffness of the joint.
By complete contrast, in a frozen shoulder, the tendons are actually still perfectly intact. There is no tear. Because the tendons are healthy and securely attached, when you perform resisted power tests on a frozen shoulder, those tests are much less affected. The muscle and tendon can still generate plenty of force. The joint capsule itself is just way too tight to allow the arm to travel anywhere.
So when you're testing a frozen shoulder, you're going to see a global restriction across multiple planes of movement. They will struggle significantly with flexion, abduction, medial rotation, like trying to put their hand behind their back, and of course, as we highlighted earlier, external rotation.
Both active and passive ranges are just completely restricted across the board.
Section 5. Gradual decline or sudden trauma. Now we transition to the third and final clue, the origin story of how the patient's pain actually started.
A frozen shoulder creeps up on you slowly. The symptoms gradually get worse and worse over a prolonged period of time, moving from that agonizing pain phase right into the stiffness phase. A rotator cuff tear, however, has a completely different villain origin story. With a cuff tear, there is almost always a sudden, noticeable change in the range of movement, normally following a specific physical trauma. This sudden traumatic onset is particularly common in the older demographic. If they say, "Hey, I fell and suddenly couldn't lift my arm," you lean heavily toward a tear. If they say, "Well, it's just been getting tighter and more painful over the last 4 months," you lean toward a frozen shoulder.
Section 6. Making your final diagnosis. Let's move to our final framework and see how this all builds together into a clear, actionable picture.
Here are the 3 distinct steps clinicians use to confidently separate a frozen shoulder from a rotator cuff tear. Step 1. Identify the main symptom. Are we dealing with deep stiffness or profound weakness? Step 2. Test the range of movement. This is the big one, guys. Check both active and passive. If active is restricted but passive is completely preserved, you're almost certainly looking at a cuff tear. If both are totally stuck, think frozen shoulder. And finally, step 3. Check the origin story. Was it a gradual, creeping decline over months or a sudden, dramatic change following a specific trauma?
By walking through these 3 simple but incredibly effective steps, what initially looks like an impossible guessing game becomes a clear, logical deduction. The clinical differences are profound once you break them down. So I'll leave you with this provocative thought. The next time someone casually mentions shoulder pain, will you know to check their passive range of movement? Thank you so much for exploring this clinical mystery with me today.